Hello, everyone. I'm Leonard August Rodriguez, the Executive Vice President for Access Medical Labs. I'd like to thank everyone for joining us on another Access Live, where we bring you insights from leading medical experts. Now, we do ask that all questions be submitted via the Q&A, as they will be answered at the end of our lecture. On today's webinar, we have an individual who is absolutely no stranger to Access Live. She's actually backed by popular demand to now discuss hormonal homeostasis and health. She is a leading expert in pain management, hormone replacement therapy, regenerative medicine, with a doctorate of pharmacy in research fellowship from the University of Michigan. She is also an adjunct associate professor at George Washington University, and she is the CEO of Pharmacy Solutions. She has authored numerous works on pain management and personalized medicine, and is a sought-after speaker internationally. Please join me in welcoming Dr. Sahar Sweetan.
Thank you, Lionel, for having me again. And thank you, everybody, for spending your lunchtime with us. Hopefully, we can give you a few pearls. As you guys know, hormone is a very hot topic right now. I've been kind of in the functional medicine longevity space for way too long, for 28 years, so totally aging myself. But right now, really hormones were so vilified for so long. And as you know, there's a huge impetus now to really the black box warning that's been removed now from, with the FDA. And we really need tons and tons of what I call like really now perimenopause and menopause specialists. So hopefully let's get started and give you a few pearls as far as, what are hormones? What's the regulatory systems? What are some of the disruptions and some clinical insight where they could be helpful? So we'll talk about regulation a little bit. We'll talk about the different hormones besides the sex hormones that are really important in this symphony of hormonal orchestra, as I call it, and just kind of give you some pearls at the end. So, how does the body control really all the release of all of this stuff? And it's truly, we have to look at all hormonal systems. A lot of times we'll go, well, in perimenopause, like, okay, I'm hot flashing, I'm not sleeping, my moods are short, or men, they go through andropause, right? And really periandropause, same thing. They go, I'm tired, I'm fatigued, I'm not, I can't do the things that I used to, I can't exercise as much. But it's really not just the sex hormones. You really have to look at the energy system, the insulin, glucose, and insulin resistance. You have to look at the HPA axis. We have to look at the sex hormones. We have to look at the thyroid and the hypothalamic system. So really, hormonal regulation is maintained through a complex biochemical and negative and positive feedback system. So, the hypothalamus, it's the master regulator, the thyroid, the pancreas, the adrenal glands, and really there's a lot of loops that control all of these and these indices. Now, we know, hormones are obviously excreted by these different endocrine glands, obviously ovaries, testes, the thyroid glands, but there's also a concept called intracrinology. So where the body can actually take DHEA in the cell and convert it to these different hormones that are needed, like estradiol in the brain, progesterone in the brain, and so on. And insulin signaling, right? Like the liver and the brain does not need insulin to uptake glucose because there's such high energy, they need such high energy coefficient organs, as you know. Obviously, the incretins, right? This is another hormonal system, right? Everybody's on a vitamin GLP now, as I tease, right? The whole world is on a GLP now. So these are gut-derived hormones that again work and regulate insulin secretion after eating. Now we have the GLP-1s, the GIPs and NIPs. Now we have the glucagon inhibitors that are coming out, and now they're probably going to have, level 4 of these that are already in development. So, these are synergistic actions, obviously, with the energy, glucose, insulin control systems. And again, this is a very tight, we have negative feedback. Obviously, insulin secretion is reduced when blood glucose levels are obviously normalized or if they're low, and obviously positive, when after you eat, obviously insulin levels, go up to obviously help regulate or uptake, glucose into the tissues. Oxytocin, right? This is a positive feedback example. For example, oxytocin, I always tease the world is very oxytocin deficient. Remember, oxytocin is the love hormone, it's the cuddle hormone. But oxytocin, obviously, during childbirth is increased during childbirth to increase uterine contraction, but it also helps with that bond in cuddling, in you moms. Now, everybody, like I said, is oxytocin deficient. Everybody needs to increase their oxytocin levels in different ways. So, like giving somebody a hug, and it's going to be at least a 20-second hug, can actually increase your oxytocin levels. Things that give people happiness, whatever, that is for you, that can increase oxytocin levels. So again, not to belabor the point, there's a lot of different hormones. So when people say like, I'm hot flashing, I don't feel good, I'm not sleeping well. And sometimes we do give them, let's say you give them estrogen and progesterone, but they still have the same complaints. My point with showing you some of the different intricacies is if their sugars are off, they're still going to hot flash. If their HPA axis is dysregulated and their stress and cortisol levels are off, they're still going to hot flash. So you really do need to look at all these different systems. If their thyroids are off, they may not feel as well as they should. So all these, the leptins, the ghrelins, the adiponectins, these are also hormone signals that obviously are important for nutrition and eating and satiety and things like that, but also very important in looking at the whole picture when people still don't feel as well after you give them hormone replacement therapy. So dysregulation of hormone feedback, can lead to obviously diabetes, obesity, and fertility. So, effects of ghrelin and leptin on obesity-related gene, they work on the Sertoli cells. So sometimes there's also links that could be to hormonal reproductive issues when those systems are off. So a lot of times, sometimes I'll say when somebody's not getting the effect, the effects that you want, we have to look up higher. So I always say you want to stop from head, to anus, literally. And the hypothalamus, obviously, this is really the master regulator of all hormones, right? The hypothalamus, regulates a bunch of different bodily functions via neural and hormonal pathways. This acts as the master regulator of all of these. So obviously it controls temperature, it controls hunger, it controls thirst, circadian rhythms, reproduction via the pituitary gland. So for example, GnRH has to be released from the hypothalamus, and then it goes to the pituitary. We release FSH and LH, and then that goes to the ovaries or the testes to release the sex hormones. Similarly to the thyroid, the hypothalamus releases thyroid releasing hormone that goes to the pituitary to release TSH, and then TSH released from the pituitary to the thyroid gland to release obviously T4. So definitely sometimes when things are not making sense, hormonally speaking, a lot of times we're not looking high enough at the hypothalamic system and looking at the hormones that are coming out from the hypothalamus. Because if you have failure in the hypothalamus, guess what? The pituitary is not going to get the signal to release FSH and LH to release the sex hormones or the thyroid hormones or ACTH. Obviously, that goes to the corticotropin releasing hormone that goes to the pituitary, and ACTH is released obviously to go to the adrenals to release cortisol. So very important to really look at these first order neurons, if you will, that basically signal the second order neurons to release all of these different hormones that I mentioned. There's also really a condition, there's hypothalamic inflammation. Now, I tease, I gave a lecture and I literally called it inflammatology, the only medical specialty left, right? And we can really link inflammation to a lot of different disorders. So now there is something that's called hypothalamic inflammation, and really it's probably just like anything because of the toxic soups that we live, these constant stress that everybody's on. That could be playing a role in obesity and metabolic syndromes. Sometimes this is triggered by aging, inflammatory, conditions, mold, Lyme disease, toxins, heavy metals, you name it, right? And that seems to activate the inflammatory pathway like NF-kappa, GNK, and innate inflammatory system, something what we call chronic inflammatory response syndrome. So a lot of times when people have metabolic inflammation, hypothalamic inflammation, it really can promote metabolic dysfunction. It can kind of, screw up these negative feedbacks in the loops and the levers and pulleys. So sometimes definitely might be good to look at these, inflammatory markers. So, you know, the hypothalamus, as I mentioned, it controls reproduction via GnRH. This is why peptides are also taking off, right? Now, there's a lot of regulatory issues with peptides like, ipramorelin, sermorelin, BPC 157 gets pepsin. And, obviously, we're not going to go to peptides in this lecture, but, this is why peptides can be very important for the healing journey of patients. So, Kespeptin is one of the peptides, and this is really a key activator of GnRH. So sometimes when people hypothalamic dysfunction, hypothalamic inflammatory syndromes, something like Kespeptin, the peptide, can kind of reboot that system. It activates the release of GnRH, and it can go to the pituitary to release LH, FSH, and obviously release the rest of cascade. So the interaction of Kespeptin, what's really interesting is, nitric oxide also modulates Kespeptin and acts as a brake. So again, the body always has these levers and pulleys to kind of keep everything in balance. And this is where sometimes, when we have these other conditions like hypothalamic amenorrhea, that's a GnRH deficiency and can cause infertility. And this is why it's important sometimes, when you have people with infertility issues, PCOS, which they tend to have a high level of inflammation, it might be good to get these levels up high to see, hey, are we getting the signal from the top or are we not? Because then the signal downstream and the downstream cascade is not going to work well, obviously. Obviously, as we get older, unfortunately, things just kind of age also, and you get more inflammation. So hypothalamic role in aging and neurodegenerative disorders, right? Aging leads to these changes in hypothalamic. People they metabolize things slower, energy slows down. So, this is where a lot of this, longevity medicine, these senescent selling, aging stuff like rapamycin and fisetin and other things that we're looking at, metformin, to see, hey, can we take these dead cells out, if you will, and obviously increase people's, health span. The next system too is, the hypothalamic pituitary adrenal axis, right? The HPA axis. Now, you see this in your patients all day long. Everybody is tired and wired. Everybody's under constant stress, right? We used to have, short bursts of stress, which is not bad, right? The body's designed to kind of deal with these short bursts of stress and then relax. The problem is everybody is constantly on 24/7. The saber-toothed tiger is chasing everybody all day long. So that really leads to this HPA dysfunction, right? So now the cortisol is secreted like all the time. And we know high cortisol, which eventually sometimes people will go to a flatline cortisol curve. Obviously, cortisol, it's a huge regulator of inflammation, metabolism, immune function, stress adaptation. This is when people are constantly getting one viral illness after the next and getting sick. Even in young kids, get a 4-point cortisol on them and you'll see exactly where the problem is. Stress detection triggers obviously corticotropin releasing hormone from the pituitary, from the hypothalamus, ACTH from the pituitary, and then we keep kicking out these excessive amounts of cortisol, which again, in short bursts, it's not an issue, but chronically, they can lead to a lot of inflammatory dysregulation and immune really suppression and dysregulation. So very important. And also when the cortisol and people are wired and tired, they tend not to sleep well. It's really not allowing them to go into the deep sleep. And that's when the glymphatic system and also the brain is kind of taking the garbage out at night. So very important to look at HPA system, 4-point cortisol. And I'll give you kind of a clinical tidbit. If you get a 4-point cortisol, and if the patient, for example, the ones that usually complain, like, I can't seem to calm down for bedtime, if they have a blip of cortisol like between 3 and 5 p.m., if you give them 2 to 300 milligrams of phosphatidylserine, um, if 2 to 300 milligrams of phosphatidylserine at like 3 to 4 p.m., you will be amazed at how that blunts that cortisol rise at that time, and they will sleep so much better for you. So phosphatidylserine is amazing at really getting these bumps of cortisol down. If somebody has mind chatter, they just go, God, I get up in the morning and I just don't feel well rested, and they're antsy during the night. And you'll see that a lot of times you'll see like their cortisol level continue to stay up during the night or a huge blip in the morning. L-theanine, like 200 milligrams at bedtime, is beautiful for shutting um, mind chatter. So very important, this is the problem why people can't sleep, right? They're going, whoa, they're going a million miles an hour. And then we think like, oh, 10 o'clock comes. Here you go. Sledgehammer, just go to sleep. You really have to work on this HPA axis throughout the day. So using things like L-theanine, 1 to 200 milligrams BID to TID will help regulate the HPA axis through the day. For people that are just wired and tired, Relora, which is a philodendron and magnolia extract. Relora, again, 1 capsule BID, is beautiful for modulating the HPA stress response syndrome. And then people can stay modulated and calm throughout the day. And then they can also sleep better. Why do we care? Why do we want to modulate the system? Well, we want nicer, happier people, obviously. But also sometimes that can lead eventually to like quote unquote exhaustion, depression and other things. When people are kind of like remember when people are like they go, I feel so puffy, I'm retaining water. Well, that's a disruption in the glucocorticoid mineralocorticoid systems, right? Because they're under and spewing probably a lot of like cortisol and mineralocorticoids. So definitely, this is a system that needs to be modulated. If people have high cortisol chronically, we know that can lead to hypothalamic shrinkage. They've shown this on neuroquant MRIs, volumetric shrinking of their hypothalamus. Also memory, right? This is why when people are in this fight and flight, their frontal cortex is not going to work as well. And that's why we want people calmer, happier, because we want their frontal lobes to be working at a much higher capacity, obviously. So very important to look at the HPA axis. And we know stress and cortisol can cause also epigenetic changes. It can lead to immunosuppression and some other chronic illnesses. So it's not good in the long term, obviously. Now, sex hormones, obviously probably everybody's favorite topic, especially now, right? We kind of vilified the role of hormones. Oh my God, they were causing cancer, they were killing people. And really, it was not the hormones. There's absolutely judicious use of hormones. Not everybody is a candidate for hormones. And also, the FDA is removing the black box warning. I think the most important thing for you guys to understand, and I did a webinar prior to this and access, the library, you should really watch the other one where I clearly go through the different forms of hormones, the types, because it's not a class effect. Bioidentical hormones work very differently than the synthetic estrogens and the progestins. Methyl testosterone, which you should never use, works very differently in the body than bioidentical testosterone. So very important to understand it is not a class effect. Oral estrogens can increase the risk of clotting. Transdermal estrogens have not been shown to increase the risk of clotting. So again, very important to understand the nuances so you can better serve your patients, because not all hormones are created equal, and it's not a class effect. There's definitely subclass effect with efficacy, with risks, and then how you use them for each patient. So obviously, sex hormones regulate reproductive and non-reproductive functions. Estrogen and progesterone and testosterone, obviously, males and females have the same hormones, right? But it's just a balance, right? Testosterone are more, men are more androgenic. Obviously, testosterone levels are higher. Women tend to be more estrogenic, but Remember, we are not giving people hormones when they're, to make them fertile myrtles at 80 or at 60. But, because every single cell in your body has receptors for these hormones. So we are trying to, basically increase memory, mobility, and function at that point and keep skeletal muscle health. Probably the best bank for longevity has been shown muscle building. Definitely, if people don't want to exercise, at least if you can give them to lift weights 2 to 3 times a week, obviously we want them to do the other stuff, but at least build their muscle reserves. It's probably the best thing that you can do for longevity. So again, these estrogens are very important for bone health, brain health, cardiovascular health, skin health, hair health, and you know it. Um, Very important. Definitely testosterone. A lot of times we think, oh, testosterone is just for libido and sexual function. But again, huge effect, very cardioprotective in men. The Traverse trial showed that really it does not increase the risk of heart disease. And if anything, it's much more protective and anti-inflammatory. Testosterone, very important in women, not just for sexual dysfunction, but really even for bone health, heart health, breast health. So very important to really look at all these in that. Progesterone, again, progesterone, bioidentical progesterone, very different than the synthetic progestins. Do progestins shed the endometrial lining? Very good. Absolutely. It's very, the progestins are very good, like medroxyprogesterone, at shedding the endometrial lining. However, they are not the same functions as progesterone. Progesterone is very neuroprotective, very brain protective, heart protective, bone protective, skin protective. So very different. Progestins do not confer the same protection, with the exception of endometrial and ovarian protection. Progesterone, very important for keeping the myelin sheath on nerves. That's why, people with MS, very important to balance their hormones because estrogen increases brain-derived neurotrophic factors in them, and progesterone is really important for keeping the myelin sheath as healthy as possible. Sex hormones are very important for cognitive health. There was a big debate, in a lot of studies, which I'll show you, they're showing like, oh my God, hormones are causing dementia. And, you wonder like, well, when people have their hormones when they're younger, I always tease like, let's just use God's textbook of medical physiology. Are people more demented when they're young or when they're old? Well, when they're old, what do you lose when you get older? Hormones. So, how can hormones be bad for cognitive function, right? So, and they're all important for cognitive function. So, definitely estrogen and progesterone enhance memory consolidation. Testosterone affects spatial memory in both males and females. So, very important for spatial, recognition, falls, if you will. They also modulate the neurotransmitter systems, acetylcholine, right? The hormone of memory, glutamate, exciting. You need that in learning and memory. So very important. Sex hormones and cardiometabolic health, definitely sometimes lipid dysregulation occurs. What's the number one killer of women? It's not breast cancer, people, right? It's heart disease. And really, hormones in the right person are very heart protective. So estrogen, testosterone, and progesterone, they regulate cardiovascular and metabolic health. We do see sometimes lipid metabolism, glucose metabolism, energy expenditure changes. So estrogen is linked to lower LDL cholesterol, reduce atherosclerosis risk in premenopausal women. And multiple studies have shown now the earlier we start people on hormones in the perimenopausal to early menopausal state, the more protective they are. Testosterone, we know, influences insulin sensitivity, glucose metabolism. This is why a lot of times women will gain 10 to 15 and 20 pounds around menopause if their hormones are not balanced because of these issues. Obviously the big question is always, do these hormones, if we replace them, cause cancer? And cancer is multifactorial. I think this is where we need to, sure, can hormones be potentially one of the causes in the wrong patient? Yes, but cancer is very multifactorial. More of the studies now are really showing that really, just like with testosterone, we used to think, oh, that led to prostate cancer. But now we're thinking, more of the recent study shows it's actually testosterone deficiency that may be contributing to prostate cancer. And, some of the, again, I think the studies are catching up in women, but, definitely, I mean, if somebody has cancer, still the recommendation is to wait. You never touch hormones in a current cancer patient unless you are discussing all of these things with their oncologist. Obviously, if it's hormone sensitive versus non-hormone sensitive, definitely there's a lot of things that you have to take into account. But, for the most part, if they don't have history of cancer, if you keep all of the other things in check, probably the likelihood of causing cancer from hormones is extremely low. Multiple studies have shown now, actually, if we give bioidentical estrogens and progesterone, not progestins, progesterone, actually the risk of breast cancer was either nullified or actually reduced in those studies. And they were large studies. Some of them were as many as 80,000 women in the study. So they were not small studies by any means. The adrenal hormones, we talked about them a little bit. Cortisol, obviously the stress hormone, DHEA, very important to check DHEAS level, 4-point cortisol. Again, DHEA is the body's endogenous anti-inflammatory system in addition to cortisol. It's very involved in energy metabolism, immune response. This is where a lot of these young kids, if they keep getting sick and sick and sick, get a 4-point cortisol, get a DHEAS, and modulate the HPA axis, and you can see how their immune system works so much better with that. So that's definitely higher cortisol levels linked to reduced natural killer cell activity. This is what kills, bugs and viruses and things, and definitely positive correlation between high cortisol and low NK cell activity. Constant high cortisol is immunosuppressive, right? This is why it can lead to these chronic diseases and maybe potentially, cancer. So again, very important to modulate this cascade. DHEA, before the advent of nonsteroidals in the 1940s, we used to have a drug called Pracetone, and Pracetone was DHEA. It was the NSAID of its day. So DHEA is very anti-inflammatory, immunoregulatory. Low DHEA levels have been linked to metabolic syndrome. Significant difference in DHEAS levels between schizophrenic patients with or without metabolic syndrome. So again, very important, as you know, in the psychiatric patient, a lot of the drugs, unfortunately, that we have cause weight gain and metabolic dysfunction. So this is one way that we can help to regulate their HPA axis, which can obviously help with their neuropsychiatric issues, but also to balance the DHEA because it can really help with maybe some of these cardiometabolic stuff. So always look at the cortisol DHEA ratio. It's one of the markers that we can do from a blood test, obviously, to look at the stress response. If they have a high ratio, sometimes it's linked to potentially increased cardiovascular risk, depression, decreased immune systems, physical activity. Definitely, this is one of the ways, people can deal with stress. Obviously, regular exercise, weightlifting, happy, whatever their happy zone is, as I call it, Tai Chi, meditation, all that stuff. DHEA supplementation, DHEA, like I said, there's tons of studies in the immunology literature and autoimmune disorders. So this is definitely in the autoimmune literature. They've used, anywhere from 100 to 2 to 300 milligrams of DHEA as an immune modulator, actually, for lupus and other disorders. So DHEA improved bone mineral density, disease activity, and fatigue in patients with lupus and rheumatoid arthritis. Again, they've shown some effects. Like I said, tons in the autoimmune literature for DHEA. So very important to look at that system. Use adaptogenic herbs like ashwagandha, rhodiola, with calming herbs like the L-theanine and Relora that I mentioned earlier, and augment DHEA levels if they're low in patients. You can use pharmaceutical grade DHEA either from some of the pharmaceutical supplement companies or from compounding pharmacies, because you want DHEAS levels in the normal and optimal ranges. So definitely, this is a system that needs to be modulated, and sometimes that's a biomarker for age-related diseases. So very important. They've shown also like abnormal cortisol curves have been implicated in many neuropsychiatric illnesses, and so again, very important system to modulate. Okay, let's go through a little bit of the, hormone replacement a little bit and what are some of the studies quickly that have been shown. Obviously, now HRT, I'll condense it for you. We want bioidentical, the 10 million women study. Again, go back to my prior lecture with Access Labs here in their university educational setting, and listen to that lecture because I really deep dive into the different forms of hormones and things like that. But again, just to reiterate, the 10 million women study showed that bioidentical were much better than synthetic. Low to medium doses had better outcomes than high doses. So again, when you replace hormones, we want to use bioidentical physiological doses. Transdermal were much safer in the estrogen realm for sure. And then progesterone, orally or vaginally, were the only ones that showed endometrial protection. But let's dive into this a little bit just to kind of give you, and I'm not going to go through all the studies and bore you, but I always put lots of studies here for you guys to kind of help the naysayers educate themselves, as I always say. So why do we give people hormone when they're older, right? Because we want to protect memory, mobility, and function, right? We're not making them fertile myrtles at 70. So bone health, heart health, brain health, vasomotor symptoms. It's not because just hot flashes are annoying. Hot flashes have been associated with increased cardiovascular disease risk. So the worse the hot flashes, the higher risk of cardiovascular disease. So very important to control some of these symptoms that women complain of, and obviously men. Now, most of the studies have shown now that earlier we start hormones, when they start the perimenopausal to the menopausal dance, the better the protection. So we have this magical 10-year window where if the hormones are started earlier, the benefits we reap are much better. We are not going to discuss the Women Health Initiative trial because honestly, it's an atrocity that cheated probably 25 years now women that should have been on hormone replacement therapy that did not reap the benefits. So think of your 75-year-old women that are coming into your practice now, the 70 to the 75 club, because this is going to be the women class that basically when the Women Health Initiative trial came out in 2002 and everybody stopped hormones on everybody, these are the women that you need to watch even more carefully because unfortunately they did not get the cardiovascular, brain, and bone protection from hormones. Obviously, lifestyle matters. Hormones are not the only thing that helps these things, but definitely it's one of the big tools that really helps these things. So bone health and HRT, again, I'm going to have lots of studies here for you. I'm not going to belabor the point, but hormones are critical for mitigating the effects of estrogen deficiency on skeletal bone health and muscle. Estrogen deficiency accelerates bone turnover, leading to net bone loss and increased risk of fractures, right? So just like cardiovascular disease is the number one killer, and even in cancers, guys, breast cancer is not the number one killer in women now. It's actually lung cancer. So that's another discussion. But we know HRT not only improves bone mass, but also maintains bone microarchitecture, reducing fracture risk at multiple skeletal sites by 20 to 40%. Evidence show that mean, bone mineral density increase of 3 to 5% in the spine and 2 to 4% in the hip within the first 2 years of HRT. So even for women that were not placed on HRT when they should have been early perimenopause to menopause, they still can benefit from these. You may not get the same big effect as we hoped when you started it earlier, but it can still be beneficial. Looking at estrogen progestin therapy, again, remember, these are synthetics, reduce hip fractures by a huge percent, estrogen alone, but you would never give estrogen alone in somebody that has a uterus, of course. But remember, progesterone is not just to shed the endometrial lining. So you never want to give estrogen alone ever, even in people that don't have a uterus. Progesterone has over 300 functions in the body. It's not just to shed the endometrial lining, which is one of my huge pet peeves, as I call it. The Million Women study, again, lower fracture risk. And HRT was consistent across various doses and formulations, so suggesting broad applicability in clinical practice. So definitely, a lot of help. What happens if you stop hormones? The cessation of HRT is associated with rapid bone loss and increased fracture risk. So basically, they start losing about 4% annual loss in bone mineral density, the lumbar and spine and hip after discontinuation. And obviously, that increases the risk of fractures. Studies such as the PEPI trial and the PSFS trials highlight the risk associated with discontinuing. Basically, multiple studies showed that, again, you get anywhere from 2 to 4% annual bone loss when these are stopped. Now, in women, not all women can get hormones. They looked at these estrogen receptor modulators like raloxifene. Again, it can help, but it's not as helpful as the bioidentical hormones, but it can help in women that are not candidates for hormones. Their efficacy in preventing, again, is limited as compared to those. Now, dosage forms, remember, oral HRT is what they use really mostly in the Women Health Initiative trial. They use the horsey estrogens, as I call them, the conjugated horsey estrogens. What they mostly used was the 0.65 milligram per day. Again, nowadays, if you learn nothing from my lecture today, which hopefully you got more pearls, never ever give estrogens orally, right? We increase the risk of clots that we don't need to do. We increase the risk of gallbladder stones and gallbladder disease. Sometimes we can cause lipid dysfunction depending on the form. So really, estrogen should always be transdermally, whether it's patch or creams, never orally. So what are the dosage form for bone health? So most of the studies have shown minimally you need an estrogen patch of 0.025 minimally, but ideally it should be 0.05 milligram per day. And again, if you're using gels like a estrogel, even mist, and those kind of things, you need an estradiol of 0.5 to 0.75 milligrams of estradiol. Now, if you're using bioidentical compounded like a biest, you want to biest 50-50, 1.5 milligrams, because that will give you 0.75 milligrams of estradiol and 0.75 milligrams of estriol. So those are the different estrogen doses that have been shown to be bone protective. And here I have them here in summary for you. So 1 to 3 milligrams orally, you never do that, but I wanted to show you the studies. And in the patches, 0.025 milligram, to 0.1. Most women probably will not tolerate the 0.1 because that's too high. Most women are going to be really in the 0.05 milligram patch. And like I said, if you're using creams, you want to be in the estradiol 0.5 to 0.75 milligram. Testosterone, most of the studies looked at 150 micrograms to 300 micrograms daily of transdermal. So again, 0.15 milligram to 0.3 milligram. Women do not need a lot of testosterone. Most commonly, transdermally, you'll see will give 0.5 to 1 milligram transdermally in a cream. DHEA, again, most women will need about 5 to 10 milligrams. If they're really low, this is a little bit on the high end for women, but sometimes for bone protection, they may need a little higher. So you will slowly start at 5 to 10 milligram. Check levels, and then you would adjust. Progesterone, the studies have shown that you need 200 milligrams 10 to 14 days per month for endometrial protection. So 200 milligrams per 14 days per month, or 100 milligrams daily. Transdermal progesterone has not been shown to infer endometrial protection. Very important point. Now, vaginal progesterone has been shown to infer endometrial protection. We get that question a lot. So, oral and vaginal progesterone has been shown to infer endometrial protection. Transdermal progesterone has not been shown to confer that. So, we recommend mostly using oral or vaginal progesterone. Again, most women, when they're menopausal, you're going to use 100 milligrams QHS, check levels and kind of adjust accordingly. How about heart? Definitely same thing. Timing of HRT initiation is critical. Initiation within the first 10 years, very cardioprotective. The earlier, the better. It helps with lipid, it helps with the glycocalyx, that slippery thing that we keep everything nice and smooth in our arteries with no cracks and crevices. The Nurses' Health Study showed a 40% reduction in coronary heart disease among HRT users. It improves lipid, it improves, like I said, nitrous oxide production, all these good things that keep you heart happy, right? So definitely no significant association with cardiovascular disease mortality in women who initiated HRT within 10 years of menopause. That was always the concern. Ooh, if we start hormones after 10 years, women have a higher risk of cardiovascular disease. What do we do? What do you do with the women that after the 10 years and they were not started on hormones? This is where you have to do a risk versus benefit analysis. So we always recommend really that you get a baseline coronary calcium score on all men and women at age 45 to 50. It's kind of like a colonoscopy. What are they doing inside their arteries? Get an IMT, right? IMT, look at intimal thickness. Do they have plaques? If they're plaquing here, guess what? They're plaquing in the head and they're plaquing in their heart. So these are simple tests that we can get. You can get clearly test on these patients to assess their soft plaques and hard plaques. So you can make a decision if HRT, if they have extremely high risk of heart disease, what are the risks? What are the benefits? Where can you help with their glucose metabolism, their lipid metabolism, and so on? So the KEEPS and the NORA studies basically highlight the cardiovascular risk of early HRT. 40% reduction in hip fractures in the NORA study and improved vascular health. KEEPS trial showed reduced progression of coronary artery calcification if we started HRT within 3 years of menopause. So again, if it's early calcification, maybe hormones may slow down that. And obviously you want to modify all the other risk factors that they do. Now remember, oral will increase the risk of thromboembolic events. Transdermal estrogens have not been shown to increase the risk of clots. Oral has, transdermal has not. We have several studies. Now, that I never say never, right? There's always one patient that will prove you wrong, but they have not been implicated in increasing the risk of clots with transdermal. Raloxifene, again, was also looked at. It's a selective estrogen receptor modulator, as I mentioned. It can increase the DVT risk. So again, somebody with high risk of DVTs and things like that, this may not be the best option for them. So what are the formulations? Again, they studied the orals in the old days because that was the Women Health Initiative trial. But even the horsey estrogens reduce coronary calcium progression when initiated early. Again, because of the risk of clots, we only recommend using estradiol patches and the transdermal, estradiol. So again, just remember, I'm not going to belabor this point, the earlier, the better that we can start. So as far as the doses, again, very similar to what I mentioned. Brain health, same thing. Estrogen, it's one of the things that increases brain-derived neurotrophic factors. So when all the studies were coming out or all this media stuff, oh my God, estrogens or hormones are causing cognitive decline. I'm like, how can something that increases brain-derived neurotrophic, I make the brain fatter, if you will, could be contributing to, and I improve acetylcholine and neurotransmitters, right? So anyways, very neuroprotective, When initiated early, again, it may slow cognitive decline, improve memory, and reduce the risk of dementia. The PROM trial, again, estrogen supports hippocampal. Remember, when people are under cortisol stress all the time, we cause hippocampal shrinkage. Estrogen supports hippocampal and cortical neurogenesis, right? I grow things more. Increases cerebral blood flow, promoting better oxygen and nutrient delivery to the brain. When we give people hormone, we help their sleep. Obviously, that's not the only thing that can help sleep, but when people sleep better, they go in the deeper sleep, they're also shedding all these toxins, lymphatics, right? This is when we take the trash out, is at night from the brain. So the KEEPS trial also showed with hormones, improved verbal memory and attention, reduced deposition of amyloid beta plaques, an area critical for memory. Women starting therapy within 5 years of menopause experience the greatest cognitive early initiation allies with this critical window hypothesis that we've been discussing. And again, this is just more studies to show you really increased dementia risk with late initiation. It's not because the hormones are doing that, it's just because they probably demented already. So again, very important to start as early as possible. And this is more studies for you here. And since then, too, there's 3 studies that has came out now that show that hormones really, they're not worsening, which is thank God. But the earlier, the better. Obviously, it improves attention. And again, you really don't want to use oral, you use transdermal. Vasomotor symptoms, again, very similar story. Again, the reason why we want to control vasomotor symptoms, as I mentioned, it's not, yes, they're bothersome and hot flashes are annoying and you soak the bed at night and you're going to change your sheets. But more importantly, reduces vasomotor symptoms frequency up to 80% within weeks of initiation. But most importantly, yes, we improve sleep, we improve mood, we improve daily functioning. But more importantly, it's the heart stuff. We know that the more severe vasomotor symptoms they are, the higher risk of cardiovascular disease. So again, hormones are very effective. Multiple studies have shown huge improvement, 75% improvement in reducing symptoms, play a critical role, obviously. But again, most importantly, we decrease the risk of cardiovascular disease. Again, most of the breast cancer risk increase, as I mentioned earlier, was when we used estrogen plus a progestin, synthetic progesterone. When we use estrogen with progesterone, the risk of breast cancer was nullified or actually reduced. Endometrial cancer, again, you have to make sure you give them enough. Estrogen is gas to breast and endometrial tissue. Progesterone is the brakes to breast and endometrial tissue. So you always got to make sure the gas and the brakes are balanced. So again, they use oral. You will not use oral, in very similar story to the other ones. And this is the summary for you. Now, they've used some other alternative non-hormonal in people that we can't use, raloxifene, like I mentioned, and basedoxifene. So those are the they were okay, but they were not as good as the hormones. Remember, they can potentially increase the risk of clots. For other vasomotor symptoms, some of the SSRIs like paroxetine were used. It's FDA approved for hot flashes, again, in women that can't use hormones. Gabapentin can be effective for night sweats and sleep disturbances. Sometimes some of the plant-based compounds like isoflavones and lignans, have a mild estrogen effect, like rhubarb extract and some other things that they, have tested can help, again, in maybe women that can't use hormones. So definitely very important to look at time and timing. The earlier, the better. Each person is going to require a different dose. This is where personalized medicine shines, obviously, and comes in. And this is where you can start, get a baseline labs. You start them on the therapy and then you monitor and adjust and control the risks. Cancer feeds, sugar feeds cancer, stress feeds cancer, all these things, sleeping, eating, meditation, life, connection, community, all these things really can increase and optimize your health and longevity, right? Let's talk a little bit about testing methods. So, how do you test hormones, right? There's a lot of debate. Like, is it serum? Is it saliva? Is it urine? What do I do? Now, more importantly, assay types matter. The old immunoassay types are really old and they don't give you, they were noisy. They were not very effective at just picking up the true parent compound of these. So now, you really want to work with labs that use LCMS, liquid chromatography mass spec. They get much better levels. They can detect lower levels of hormones and you can monitor treatment better. So again, make sure the labs you're working with use LCMS. Now, in the clinical literature, the gold standard really is serum testing. The problem is, it's a well-established reference range. It can measure other biomarkers like thyroid, DHEAS, pregnenolone, sex hormone binding globulin, very important. You want to look at the rest of their body, like a comp, a CBC with diff, PSA in men, obviously, and make sure. So this is the gold standard for hormones. The only time, and we'll talk about the drawbacks for this, is really obviously it'll capture only one point in time. So if they're menopausal, that's okay because they're not bopping around as much as like a perimenopausal patient or maybe a patient that's young and we're trying to capture a luteal phase defect. May underestimate topical hormone delivery. Again, hormones, which is where you want them, they don't stay in the blood very long. So when you apply a transdermal cream or gel, they go to the tissue. Now, patches, you will clock it in the serum because patches, it's kind of like almost like a main line IV that's kind of constantly shooting the hormone in. Obviously, sometimes if you puncture somebody a big needle, that may affect their stress hormone, right? Saliva is great, non-invasive collection. It measures bioavailable or free hormone. It's the gold standard for measuring cortisol. So a 4-point cortisol, even in the endocrinology literature, it's really the gold standard to get a 4-point cortisol. So, and it's teamed to assess maybe like more tissue level because it's closer to the tissue level. So here are, some of the labs that are out there. Access Labs has a 4-point cortisol, the DHEA and some of the blood testing. So the saliva testing, you don't want to use it if the patient is taking troches or buccal hormones because you're going to get these hugely elevated levels. Collection restriction, like you got to wait, like they can't eat or drink within an hour, brushing their teeth, rubbing finger with HRT. So if people are applying the cream, I always say use your wrist or wear gloves and doff them off because hormones, even though you go wash your hands, everybody thinks they're just going to go away. They will stay on your fingertips for 2 to 4 hours. So this is why you have to be careful with topical hormones and transferring to others. Not necessarily. So sometimes people will try to correlate with serum. They don't, like, you're not comparing apples to apples. So definitely a better assessment of peripheral tissue. Now, urine, I always say you have to get urine metabolites of hormones. So even if you're doing serum or saliva, at one point you want to check their metabolism. You want to make sure they're taking their estrogens and keeping them in the correct aisles. 2, 4, and 16 pathways because there are great ways that we can manipulate that journey if they're not optimized in keeping their metabolism, estrogen metabolism. Gut health is very important, and you want to look at that. All hormone patients should be on, 30 to 35 grams of soluble and insoluble fiber per day. Remember, hormones undergo intrahepatic recirculation. So very important to keep their gut health as healthy as possible. Fiber will do that, probiotics, because you want one of the metabolic pathways, which is they poop their hormones out, you want that pathway to be moving and healthy. So 25 to 35 grams of fiber per day, probiotics, lots of fluid, B vitamins, all hormones, synthetic or natural, deplete B vitamins. So all hormone patients, including birth control pills, should be on a B complex because that helps with phase 2 metabolism of hormones and very important to do that. So today you're going to do an oath that I will not use hormones on my patients unless they're optimized in their gut, they're eating clean and lean, They're taking 25 to 35 grams of fiber slowly. You're going to raise them to that. They're well hydrated, and you're going to put them on a B vitamin to keep their metabolic pathways as optimized as possible. And this is like really where, there's a bunch of companies that will do obviously the urine metabolites of these. And again, this is what I was talking to. We can do a whole lecture on metabolism, which is an important, point. But you got to make sure, again, they're going in the right pathways. You don't want that to go in the 4-hydroxyestrone because this is the DNA damaging pathway. And if they are taking most of their estrogen metabolism into this pathway, that's not good. And you want to modify that journey. Excuse me. So mass spec is the preferred method, as I mentioned. It's higher sensitivity and specificity. It can measure multiple hormones simultaneously, and it's standardized across the labs now. And today, this is really the panel that I usually start a lot of the patients with because, like I said, you want to look at the whole picture, not just their hormones. So Access Labs is running a special because of this webinar where you get a comp with GFR. CBC with DIF, I'd love to do actually a presentation on how to read your labs better. There's so much that you can tell from a CBC with DIF. Like, for example, the monocytes, eosinophils, and basophil percentage. 80% of your immune system lives in the GI tract, right? So it's a great way. You can tell so much from a CBC with DIF besides like mean volume, mean platelet volume, like the MPV. If it's high, that means they're inflamed. It's kind of a surrogate marker of interleukin 6. There's so many cool ways that you could look at these different labs. People have alk phos that's low. Well, that could be zinc deficiency, or they're not making enough acid in their stomach, right? But I love this panel because, again, you want to look at the full picture. What is their glucose and insulin doing? What's their A1C? What is their kidney function, liver function? Obviously, AM cortisol or a 4-point cortisol, preferably. What's their inflammatory system? What's their CRP like? What's their DHEA, the anti-inflammatory system, doing? Dihydrotestosterone, are they taking their testosterone and converting it too much to this? This is PCOS patients tend to do that. Obviously, the sex hormones. What are their iron? You need iron to be optimized in order for your thyroid to work, and vice versa. What's that doing? It's not just, for blood counts. Obviously, a full thyroid panel. What's their growth hormone like? What are they getting the signal from the pituitary? Lipids, very important. PSA, sex hormone binding globulin. Is this why their testosterone is low? And also, sex hormone binding globulin tells you a lot about their inflammatory state and also their cardiometabolic state. So very important, again, to really, test and don't guess. Because a lot of times people will come in with these symptoms for you and you go, oh, it's low testosterone or it's high this or high that. But unless you really see what their baseline is, you're just guessing. So I always say test and don't guess. You want to start therapy. You want to monitor not just labs, right? Labs is one part of the story, but look at their symptoms. But look at the end results. Hey, get a DEXA scan or a body analyzer. How's their bone architecture looking? How is their breast health? How's their brain? Do a cognoscopy, do a MOCA score on them every 6 months and see how they're doing. You want to check the biomarkers of your therapy, like bone health, right? Their cognition, cognoscopy, make sure their breast health is the endometrial lining, is the gas in the brake on endometrial lining balancing. So, very important to use these evidence-based recommendation with dosing that I mentioned to you, and then empowering patients to really educate them and be part of this obviously discussion. So we want a personalized approach. We want to, hormonal therapy. We want to empower them with this knowledge. And there's a lot of other studies. Sometimes we do have to go to non-hormonal interventions, and I gave you a few of the tools for that, definitely, because, we may not be able to use, but very important. You can't just slap hormones and wish for the best, as I always say. You definitely want to address all the other stuff. If they're eating very high inflammatory diets, trust me, they will continue to hot flash. You want them on anti-inflammatory diets. You want them on lean and green. You want to optimize their gut health. You want to give them anti-inflammatory diets, omega-3s if they're low on it, B vitamins, antioxidants. You want them moving. You want their stress reduced, get them to build muscle, very important. And that's how you can get some of the aggressions out per se. Wearables, everybody's using wearables nowadays, but just make sure also they're not getting radiated with the wearables all day long. So really precision medicine is the way that it's going. So I thank you for your attention, and I will turn it back to Lionel to see
Dr.
what questions we have.
Absolutely. And Dr. Sudan, amazing, amazing lecture. I mean, I have so many questions. I'm going to start with the first one, right? You opened up the deck describing, hormonal regulation as a delicate balance, right? What do you see as the biggest real world disruptors of that balance today?
I really think mostly stress. We see like such dysregulated HPA axis systems, and definitely the insulin glucose system, right? I mean, just everybody's so wired, stressed. They're not eating as we all should. Nobody's like resting and digesting. Everybody's like parasympathetically challenged as ITs, But definitely, you have to keep in mind we are swimming in toxic soup all day. The average person slaps about 150 chemicals on their body a day.
Wow.
Between health and beauty aids, work stuff, cleaning, utensils, the food that we're eating, what's in our water. So it just really takes a lot more to, I guess, live clean nowadays, between the
Yes.
stress, the toxins and things. So a lot of these endocrine disruptors are also contributing to the endocrine disruption that we see. Before we never would see a 20-year-old something with a testosterone level of 150, right? Now it's extremely common. You see it all day long, or women, 20 and 25 something with either the PCOS or amenorrheas, or I can't get pregnant, trying multiple times and things like that. So we have a lot of endocrine disruptors that are happening from the environment. Um, Insulin glucose dysregulation, and I would say the stress and HPA system.
Thank you for that. So really, I guess watching what you eat, watching what you put on your body, and trying not to stress would definitely help.
Yes.
Excellent. Thank you for highlighting that. Now, let me ask, you also mentioned that the hypothalamus is a master regulator. I think I'm quoting you correctly. Okay. So can you walk us through, what the early warning signs clinicians should look for when hypothalamic function starts to truly slip?
Yeah, so so a lot of times, we're all trained to check like TSH. So we're kind of all trained to kind of check, well, it's more like this, the pituitary down, but not like from the hypothalamus down. So, it's really when you see something like, for example, we'll see like, you'll see a TSH, let's say 10, right? High. And we go, oh, this person has, and then you have a low T3 and a T4, Um, but sometimes we're not looking for level one. Is the pituitary, not releasing the signal from the hypothalamus, like the thyroid tropin releasing hormone, to get the signal to do that? So, it's kind of complicated, and definitely we could do, like, I do another lecture on that. But, like hypothyroidism, there is type 1, type 2, and type 3, depending where the miss signal is coming from. So definitely, you check LH, you keep doing the regular stuff. But my point with that is it's sometimes, is it not working properly because it's not getting the signal from here to here first
Mm.
to go to the pituitary and to give the signal for the rest of the body. So it is really the master regulator, right? And now we see this hypothalamic inflammation, which is kind of a new thing that we're learning about. Like, I would just like, well, your body's just on fire, period, right? You know, Yeah, and it's very interesting. So I'm just listening to a podcast, and we used to think like, the hypothalamus was just inside, and then that it was the blood-brain barrier. It was inside, so nothing talked to that gland. But now, there's more data and science morphs where actually some parts of the hypothalamus is outside of that blood-brain barrier. So it is sensing, let's say, low T3, low T4, low estrogens, low progesterone. So it's definitely part of this feedback that we did not give it enough credit because we used to think, ooh, well, it wasn't seeing anything because it's inside this blood-brain barrier, where now the data showing no, it is sensing, and maybe we should be checking things higher up.
I love it, and I love how in medicine there's always something new
Yeah.
and emerging. Since we're on the topic of the inflammation, right? How reversible would you say it is with just lifestyle modifications alone?
It depends. So it depends. Yes, lifestyle can take you obviously definitely in the right direction, but sometimes if you have like a huge toxic burden, for example, heavy metals or pesticides, herbicides, mold, whatever the toxin might be, we definitely have to go next level up with detoxing the body from some of these to truly get the inflammation under control. Sometimes also we use things like low dose naltrexone that can really help balance the Th1, Th2, and Th17, not to get too technical with the immune system here too, and the histamine system, right? I literally scratch every patient really hard and they look at you weird, like, what the heck are you doing? But I'm looking to see if they have dermatographia, because if they're like, it's like the poor man's test, as I call it, kind of like when you go, here, move your glasses. Let me see if you have your outer third eyebrows are gone. Well, like thyroid dysfunction. I'll go, stick your tongue out. Is it full of white stuff and thrush, right? So much you can do. ITs, everybody's so busy monkey clicking on computers now. Everybody's so, nobody's looking at the patient anymore. But definitely, lifestyle will absolutely is important and get you in the right direction, but sometimes we do have to detox people and take the heavy metals slowly out in the right fashion. Herbicides, pesticides, get their gut health under control, because that's one of the other kind of metabolism, cleanup aisles, if you will. And use things like low dose naltrexone, Moducare, ketotifen if they have a high histamine burden. It's kind of a histamine regulator. Quercetin is another supplement that can really help with the histamine system. So yeah, there's a lot of tools that we have, and we teach, thank God, at A4M.
Beauty. And I'm going to take it back a little bit, right? So you mentioned, 20-year-old guy, 150 testosterone, that to me it's still wild, but it is becoming a lot more frequently observed. So I want to take a shift back to the sex hormones, right? And cognitive performance as a whole. So how soon after HRT initiation would you say do patients typically notice that cognitive shift and they feel better? You mentioned the young man at 28. Is it going to take him longer, or is it going to take him more time than a patient who's, his father, for example, who's twice his age?
Yeah, well, first of all, the treatments are very different. So, again, we can definitely do a men's health, but, it depends if it's so in younger males, it tends to be secondary hypogonadism, not primary. So, in general, in young men, it's not because of testicular failure or testicular kind of hibernation, going to sleep and aging, but it's usually a causation of something else. So, again, their loops and pulleys and balances are not working properly, not getting the right signals. So the treatment, first of all, is very different. So you would not use testosterone in young males in general.
Okay.
Because that can affect fertility in other issues like that, right? So the treatment modalities for young males versus older males, if they're truly in primary hypogonadism. So for older males, primary hypogonadism, it would be testosterone therapy, TRT. For young males, we will use definitely HPA balancing, clean up their diet, fix their glucose, and use other signaling agents like HCG to kind of get the testes moving again. Clomiphene or enclomiphene, would be some other treatments for males. Now, to answer your question, well, how fast do I feel better? In general, for hormones, really, it takes 2 to 3 months to really get the systems moving, get the tissues saturated, get everything happy again and regulated and kind of optimized. So, in general, we usually say like 3 months we'll retest levels and then adjust accordingly based on what we see.
Love that. And since we're on the topic of retesting levels, I'm going to jump to you mentioned cortisol and DHEA, right? And how important and critical these markers are across multiple conditions, right? How frequently should we be testing, cortisol? I don't want to give all the limelight to the sex hormones. How frequently should we be testing the cortisol and DHEA?
Yeah, so I mean, it depends. In general, we really recommend in the beginning you get a baseline and then every 3 months while you're alternating therapy. Sometimes cortisol, depending on how good they're applying lifestyle things that we teach them, like relax and meditating, eating cleaner, all that good stuff. In general, in the beginning, we recommend retesting hormones every 3 months. And then once they're optimized, really every 6 months. Now, the younger people, they're getting sick nonstop and those kind of things, and you work with them and now they're good. You just like test them, once a year or if they get really sick again. But in general, for hormone therapy, including, cortisol, DHEA, every 3 months in the beginning and once optimized every 6 months to a year max or minimal, I mean.
Beauty. So quarterly, at the beginning. Love that. Now, on the topic of testing, you mentioned serum testing, salivary testing, urine testing, each of them having their pros and their cons, right? And so as a clinician, if I had to choose one, right, for whatever the reason, which would be ideal to give me the clearest clinical picture on a patient?
So, this is where, like I said, and highlighted some of the pros and cons. Because to be honest with you, none of the testing modalities that we currently have are perfect of giving us the right answer. So, for example, if you are using a topical cream or gel of estradiol, for example, or testosterone, if you measure serum, it is an underestimate because, again, they're living in the tissue, they're not living in your serum. So, salivary or a urine test may give you better representation because it's the free fraction of what's kind of floating and living in tissue. Now, if you have like an estrogen patch, serum is totally fine to use with that. Some of like the buccal technologies, if people are on pellets, right? If they're on testosterone pellets, serum is totally fine. It's the standard of care to really measure for that. Absolutely. Progesterone is wonky, to be honest with you, in every tissue level, right? So progesterone, one caution for any testing level, if you're using oral progesterone, it has a very short half-life, right? So a lot of times we tell women to take their progesterone an hour before bedtime. So let's say 9 or 10 p.m. It has a short half-life. So a lot of times people will go draw their blood the next morning, right? And then they go, oh my God, my level is only 1 or 2 or whatever. But that's because it has a short half-life. It just has left, Elvis has left the building per se. So, the progesterone is just out of your body, but that doesn't mean it didn't do its job during the night. Like it did give you the endometrial protection. It did give you the brain protection and things like that. So again, that doesn't mean we don't, it's not working. That doesn't mean we don't need to adjust it either. So like if I see women, even though their level, let's say, is low, and they say, God, I'm still not sleeping well, I have some breast tenderness. So that gives you, again, points that, oh, their progesterone is probably not balanced with estrogen yet, and that I need to raise the dose, even though, yes, it's low. But now they come in and they go, a woman's level is, let's say, 5. Ideally, we want it above 10. But she's like, oh my God, I feel great. I feel amazing. I'm sleeping great. I feel like myself again. I don't have any swelling, no breast tenderness, no water retention, no nothing. Guess what? Leave it alone. She's fine.
Gotcha.
Again, it's doing its thing. That doesn't mean it's not there, even though the level is not as optimal as we would like. It's just people metabolize things a bit differently. This is where I like vaginal ultrasounds, honestly, once a year because, hey, is the gas in the brake, doing pretty good on the endometrial tissue, right?
Love that. And I've asked you a lot of questions. I promise this will be the last one, right?
No,
So,
that's fine. Yeah, they have a bunch of other ones. I mean, I'm happy to answer them, whatever typey also after this, if you want to keep it on. There's a
okay,
lot of great questions on the Q&A too.
I'll run through them and I'll try to
Yes.
maneuver with the ones that seem to be that correlate with one another. So let's talk about which you just mentioned pellet therapy. You mentioned the blood testing for pellet therapy. What is your overall opinion on the delivery of BHRT for estrogen and testosterone for women via pellet therapy?
Yeah, so pellets, I always say this is my general kind of like one sentence summary. You never pellet anybody at the first hello. Very important to know what is the right dose for them. How do they metabolize these hormones? Because once you stick that pellet in, you can't take it out.
Mm.
So, you know, so always know what's the right dose for them. How do they metabolize it? Have you run through the contraindications, right? Untreated sleep apnea is a contraindication for testosterone therapy in men. Have they had prior DVTs? Because you can take testosterone and convert it to estrogens, right? Is that done? So you just, again, never pellet anybody at the first hello. Once you know these nuances and the patient is properly screened, pellet therapy can be very helpful and easier to administer, right? Because you kind of stick the pellets in. There are potential complications, rare. They extrude, some infection risk, obviously. I'm not a huge fan of estrogen pellets in women just because women are just harder beasts, period, with hormones because they fluctuate so much. So testosterone pellets in women are okay after, the right dose, how they metabolize, all the potential contraindications. Estrogens, I think sometimes because they'll start bleeding, they'll doing this or doing that. Did you get the right dose? But can you use it? Absolutely, in the right person after you know the right dose and metabolism.
Beauty, and that makes complete sense. Let me ask you. So now let's talk about the treatment, right? Who, when, and where. So, what is your recommendation on using estradiol troches and testosterone versus transdermal versus the creams, the transdermals?
Yeah. So I'm not a fan of estrogen troches because you still will absorb some orally and then you get into the oral issues of estrogen. So not a fan of estrogen troches.
Okay.
Progesterone troches or sublingual, liquids of progesterone are fine. Obviously oral progesterone or vaginal progesterone has been shown to confer endometrial protection, as I mentioned. Really, estrogen I only recommend transdermally, whether it's a patch or a transdermal cream or gel or a compounded biased, combination, that would be fine. But for those reasons, I'm not a fan. Now, testosterone, um, troches are okay. Testosterone is one of those like high extraction, first pass effect kind of hormone, even more than estrogens and others. So sometimes your liver will get the bigger hit, like, he man or he woman for the liver, but it's not your liver that needs all the hormones. So can you use it? Absolutely. But again, in general, for women, the preferred route is really transdermal or intravaginal, actually. As you guys know, there is not really an FDA approved form of testosterone bioidentical for women, so it's mostly compounded. I know some people they'll use the male dose and put it in these small syringes and microdose. It gets too messy. It's so much easier to just get it compounded by compounding pharmacies.
Agreed, agreed. Now let me ask you. So the audience wants to know where can they find you outside of obviously our Access Live webinars? Where else can they get more information about Dr. Sweetan? It looks like a lot of individuals want to ask you a lot more questions. Is there a podcast? Do you have a YouTube? Just talk to us.
Yeah. Well, I said good or bad for you guys. I'm like a nightmare. I don't go away. So hopefully you like me, I always say. So I lecture a lot. Obviously, I've been with the A4M, the American Academy of Anti-Aging and Regenerative Medicine, for the past 28 years, and I've been part of their core faculty there. And I'm also the director of professional programming for our fellowship program. So we'd love to see you guys at A4M for more education. Definitely, I lecture tons there. But if you pull YouTube, you'll find a lot of my prior lectures, podcasts, or you can go to sahar.world and mastering chronic pain. I'm on Instagram, whatever, Facebook. I'm trying to think those, LinkedIn. Definitely. But, I lecture really all over the globe. So, but mostly with A4M, but you will find some of our lectures. So hopefully we see you there. We will be running module one, which is all on endocrinology in Las Vegas in December. So if you go to the a4m.com website, you'll also find a lot of information on endocrine, and I lecture tons in that also. So, well, I'm glad, hopefully you enjoyed this presentation. Hopefully you learned a lot from it. Also, if you have any additional questions, I'm happy to answer them. Sahar@sahar.world is my email. I think it's on the slides. I can't remember, but just simple Sahar@sahar.world. You can also go to my website, sahar.world. It's easy. You can find some presentations also over there, but happy if you want to email if there's any additional questions I can help with. I'm just very passionate about this. As you can tell, I really want us all to do this well. Our time has come. I've been doing and teaching this for 28 years. Hormones were very vilified, but we want you all to do it the right way, the right testing, the right doses. We don't want to just be hormone slappers, as I call it. This is a multi-systems biology approach to hormone replacement. You have to make sure the gut is working. You have to make sure the metabolism in the liver is working. Phase 1, phase 2, phase 3. Detox, we teach all of that. The right dosing, the right modalities, the right testing. Very critical to do this right. And also look at the other hormonal systems. That's why I put these additional things now to build on the prior webinar that I did here, because it's not just sex hormones. You really have to look at the incretin glucose GLP systems. You have to look at the thyroid system. You have to look at the sex system, and you have to look at the HPA axis. And all of them in concert have to be balanced to give people really the best outcomes and get you the best feeling. And, as a lot of patients will tell you, like, I just lost the pep in my step, right? So, what we're trying to do is to kind of give them the pep in their step back. So yes, thank you, Access Labs, for having me again. I love teaching, and anything I can do to help, would be happy to.
Dr. Sonano, thank you. It's always a good time. I love speaking with you. Based upon this conversation, it looks like we may have to have another lecture sometime in 2026. I definitely look forward to
Yeah.
that.
Yeah.
And please.
Yeah, I know another one. I love the Q&As, right? Just Q&As, because there's a lot of great questions as you see. Those are like the best teaching moments too. So,
Absolutely. I couldn't agree more. I love the interaction with the audience. And again, on behalf of Access Medical Labs, I'd like to thank you for this webinar. To our audience, thank you again for tuning in to another Access Live, where we bring you insights from leading medical experts. Don't forget to like, don't forget to subscribe, and don't forget to stay healthy. Till next time, everyone.
thank you, everyone. Have a great day.